Welcome to our presentation on arrhythmias, where we explore how the heart's electrical system works and what happens when rhythm goes awry. In this session, I'll guide you through key concepts, common disorders, how they form, how we diagnose them, and the treatments that can save lives, all in clear, easy-to-follow steps. Chapter 1 introduces the heart's electrical symphony, the coordinated signals that keep each beat reliable. Think of the heart as an orchestra where timing matters, and small disruptions can change the whole performance. In the next slides, we will unpack the key players and how they maintain a steady rhythm. An arrhythmia is any departure from the heart's normal rhythm caused by electrical disruption. Symptoms range from harmless palpitations to dizziness or sudden collapse, making early recognition important. This slide shows an anatomical view of the heart to help you visualize where those electrical problems can originate. The normal sinus rhythm is driven by the sinoatrial node, the heart's natural pacemaker that initiates each electrical impulse. Autonomic nerves modulate its rate, and the ECG shows upright P waves in leads I and I2. This slide pairs an anatomical image with a simple summary of how the SA node orchestrates heartbeats. Sinus arrhythmia is a normal, often benign variation in heart rate tied to breathing, speeding up on inhalation and slowing on exhalation. It is especially common in younger people and reflects healthy autonomic function. The image and chart hint at those gentle fluctuations rather than a pathologic rhythm disorder. Chapter 2 turns to how arrhythmias actually form, focusing on the electrical disturbances that disrupt normal conduction. We'll explore the main mechanisms and see how small cellular changes can scale into significant rhythm problems, setting the stage for more detailed examples in the following slides. Two primary mechanisms drive most arrhythmias: abnormal automaticity, where non-pacemaker cells fire spontaneously, and re-entry circuits where impulses loop repeatedly through cardiac tissue. These processes can arise in different heart regions and produce distinct rhythm patterns, explaining why arrhythmias vary so much in presentation and risk. When the heart slows, we call it bradyarrhythmia, often from slow SA node firing or conduction block. Athletes may show benign slow rates, but pathological causes like hypothyroidism or medications can be dangerous. This slide outlines clinical signs and why severe bradycardia can impair blood flow and require pacing. Tachyarrhythmias are fast heart rhythms that come in two broad types: supraventricular rhythms above the ventricles and ventricular rhythms arising in the ventricles themselves. Supraventricular tachycardias are usually better tolerated, while ventricular tachycardia can rapidly compromise output and lead to life-threatening deterioration. Chapter 3 previews common arrhythmias and why they matter, from harmless extrasystoles to conditions that increase stroke or sudden death risk. We'll look at typical ECG patterns, clinical consequences, and management principles so you can recognize which rhythms need urgent attention and which can be monitored. Atrial fibrillation is the most prevalent sustained arrhythmia, creating chaotic atrial activity and an irregular ventricular response. It increases stroke risk significantly, so anticoagulation is often essential. Management balances stroke prevention, rate control, and rhythm approaches tailored to the individual, with ablation an option for many patients. Atrial flutter produces rapid, regular atrial contractions, often around 300 beats per minute, and a characteristic sawtooth ECG pattern. It commonly coexists with heart or lung disease and leads to variable ventricular rates. Treatment focuses on rate control, cardioversion when needed, anticoagulation for stroke prevention, and catheter ablation for durable cure. Premature contractions are early heartbeats that originate in the atria or ventricles and often appear as extra beats on ECG. Premature atrial contractions are usually benign, while frequent premature ventricular contractions can signal underlying disease and may lead to cardiomyopathy if very frequent. So proper evaluation is important. The AV node is the electrical gateway between atria and ventricles and can be the site of both fast and slow rhythm disorders. This slide summarizes junctional tachycardia and the spectrum of AV block from first degree to complete heart block, highlighting when pacing becomes necessary to maintain adequate cardiac output. Chapter 4 focuses on diagnosing arrhythmias and the tools clinicians rely on to capture electrical activity. Accurate diagnosis determines the right treatment, and modern monitoring has made it easier to catch intermittent or silent rhythms that standard testing might miss. The 12-lead ECG remains the diagnostic cornerstone, revealing rate, rhythm, and conduction abnormalities. For intermittent events, we use Holter recordings, event monitors, or implantable loop recorders. And, for complex cases, electrophysiology studies map electrical pathways to guide targeted therapy. Ventricular fibrillation is the most lethal arrhythmia, with chaotic electrical activity producing no effective heartbeat and rapid cardiac arrest. Immediate defibrillation is life-saving, and every minute of delay reduces survival, which is why accessible AEDs and quick recognition are so crucial for outcomes. Chapter 5 introduces treatment and long-term management options, showing how therapies range from lifestyle and medications to advanced device interventions. The right strategy depends on rhythm type, symptom severity, stroke risk, and individual patient goals, aiming to restore safe and effective heart function. Managing arrhythmias spans acute medications to long-term devices. Bradycardia may need temporary measures, then permanent pacing. Supraventricular tachycardia often responds to vagal maneuvers, drugs, or ablation. Atrial fibrillation requires anticoagulation and tailored rate or rhythm strategies. And ventricular arrhythmias may need antiarrhythmics or ICDs to prevent sudden death. In conclusion, early detection and tailored treatment dramatically improve outcomes for people with arrhythmias. Advances in ECG technology, catheter ablation, and device therapy offer real hope. So regular monitoring, prompt evaluation of symptoms, and appropriate intervention help preserve cardiac health and save lives.